Thank you for joining me today at this talk on contemporary keratoconus treatment strategies. I am Clark Chang, and just wanted to show you my full financial disclosure. I always believe in disclosing more than required, and so there so many of these that I'm listing here are not relevant to today's topic, but I do want to give a special shout out to say thank you to my fellowship supervisor, Dr. Peter Hirsch. He was my mentor when I undertook my cornea and contact lens fellowship, so I've always liked to give credit where credit is due, as well as to Dr. Angela Shin, who did amazing work as a cornea fellow after me, putting together study results, and some of which I will be presenting in a little bit. So regarding keratoconus, I think we're all very comfortable with the classical definition or in terms of what keratoconus is, right? Progressive apical thinning, typically inferior, maybe even inferior temporal protrusions. Here I have a patient with, just to show you how unpredictable this disease can be, there's a small percentage of population that will have superior apical thinning rather than inferior. Typically not associated this disease with vascularization or inflammatory findings on the cornea. I think we can debate a little bit about the inflammatory findings, but that would be at a future time. Due to the time constraint. And typically we expect the life cycle of starting early on, first to second decade of life, and slowly stabilizing towards the fourth and maybe even the fifth. But I will, warn my patients about the fact that there's not really an age ceiling where the disease can sort of intermittently stop and go, so it could stabilize for a while and then continue to progress. It could also progress well into the 50s and even later, especially for conditions like ectasia, because the onset is later, and therefore it's something that you just have to be compliant with close monitoring. With annual exams and or other guidelines, maybe even more frequent than once a year. Prevalence rate, we typically quote 1 in 2,000. And looking at this table from the Hashemi study, the 1 in 2,000 is the 54 in cases per 100,000. You can see there are definitely countries like India, which is 40 times more, Israel, 40 times more, Lebanon, 60 times more, and on and on. So it certainly shows us that the prevalence rate is something that whether due to the instrumentation sensitivity that we have now or just understanding of what to look for, it is very possible that the prevalence rate is higher than 1 in 2,000, possibly a conservative estimation from a recent paper from the Netherlands after reviewing 4.4 million cases in their country, came up with a prevalence rate of 1 in 375. So again, this is maybe a disease that is holding a lot more impact to public health than we ever expected. So the question would be, what kind of causes, right? But still, our understanding is that it's a multifactorial, which stands for we don't really know, right? Genetic, we believe, plays a very big part of this disease, but in literature, only about 6 to 24% of cases reported has some sort of family genetic history that we can trace. So we think that may be weakening tendency of the cornea due to genetic makeup, but then also superimposed with the external environmental factor like trauma from eye rubbing, atopic disease, that type of thing. And possibly with eye rubbing comes with increased surface temperature that can bring about proteolytic breakdown, excuse me, as well as IOP spikes during the period of eye rubbing. So those are all kind of things that we do have to actively educate our patients on avoiding. And certainly if there are any stimulus that we can control, such as allergies, such as dryness, we need to very actively and very aggressively control those conditions. And bilateral condition, again, kind of supports the genetic spaces of it, but highly asymmetrical, not only within the same eye, meaning inferior, superior type of asymmetry on the cornea, but also bilateral or intraocular asymmetry, one eye typically much worse than the other. And the weakening corneal contour leads to optical and visual consequences that often is related to the irregular cylinder and higher order aberration, and that we know very well of and are able to control a lot of times with glasses and especially contact lenses. And obviously these, if you have any instrument that is capable of capturing wavefront sensing, whether it's an aberrometer or even like a Scheimpflug image that has the capacity of capturing cornea or the entire eye high order aberration, that certainly will be an added piece of information clinically to be able to diagnose our patients. So continuing with the line of logic with regard to eye rubbing and trauma, again, just make sure that we do educate our patients, because we don't really know how hard or how frequently or how fast does each rubbing episode has to be, in order to set off some sort of imbalance and takes the cornea away from its equilibrium and destabilize it. We don't know that, and certainly brings about question with regard to whether or not a gas-permeable lens, a corneal GP specifically, that sits very close to the cornea, or maybe just one that is not well fit onto the cornea. Is it possible that even something as light and as small of an object as a contact lens can serve as a source of trauma, regardless of what the reasons may be, and hopefully we can elucidate that with more research in the future. Regardless of what the causes are, we know the end result, right? We know that we lose keratocytes, apoptosis, which brings about reduced biomechanics. So certainly possible in the future we could use that as a way to detect this disease. So conventionally, when we are treating this disease, we pay a lot of attention to irregular optics, because that is what we do better than anyone else, right? And certainly even when surgeons are offering corneal transplantation as a way of controlling this disease, it's also really to improve upon the irregular corneal optics. And therefore, that really is typically where we thrive, right? Like whether we're approaching it from a surgical point of view or from a contact lens point of view, that's really all that we do. And so patients typically get very frustrated because their eye gets weaker, and then the condition gets worse, and the irregular optics keeps getting worse, and they come back and have to change their glasses, change their contact lenses, until they, at some point, a group of patients will say that they give up. They may or may not be contact lens intolerant, but they certainly feel like they are, and therefore they're forced to choose between contact lenses and a corneal transplant. So if we're able to then control their biomechanical weakening, which is more the upstream problem, right, rather than downstream just trying to be able to improve upon their optics for a keratoconic cornea. If we're able to do that, then we can certainly slow down or stop progression and being able to stop the deterioration of corneal optics. And that is really the basis of the newer model. No longer are we sort of asking patients to do a binary forced choice where you choose contact lenses or corneal transplant. If we could detect them early enough and stabilize their condition so they hopefully have not lost quality of vision, or have only lost very minimum and can be rehabilitated by contact lenses that will now last for a long time because their corneal condition, their keratoconus is stable, or at least stable for a much longer period of time, then they'll be much more compliant, much more happy with our recommendation as well, because now they're not frustrated with constant changes of their glasses and contact lenses and that kind of thing. So this newer model will bring us closer to not only making these patients much easier to manage, which sounds like a dream come true for, I think, us optometrists, but also bring about much better quality of life to our patients, which is obviously very important. So therefore, if we only rely on our sort of classic textbook signs to diagnose our patients, like your Munson sign, your eye drops, obviously once you get to that point, I don't think you even really need topography to diagnose the patient. You may need it to monitor the patient, but not to diagnose the patient. So what about like scissor reflex, your Charlot sign, or your oil droplets reflex, your Razzuti sign? Typically, that means a certain amount of anterior corneal contour has changed, and therefore corneal optics changes in such a way that you're able to see what happens to light being transmitted through the cornea. Again, not the, if you think about the fact that there's not much change that has already happened, they're not early keratoconus either. And, Fleischer ring, obviously you have to have enough of an elevation contour changes in order for the iron deposit line to occur. So that's also out. So if we have to rely on an instrument in our clinic or some sort of sign, I would say probably like some sort of ring projection, like a Placido disc system, whether it's even just manual Placido ring projector. If a lot of auto or even topographer has like a ring projector that you could look at that can be printed out, especially topographers, or even just a manual keratometer that just looking for warpage. I don't care if the drum ends at 52 and couldn't go any steeper. Really, just looking at whether or not there's oval warpage on the keratometer sometimes can also be able to help us catch earlier keratoconus stages, patients in earlier stages, and that's because the epithelium can remodel. So you see here that the epithelium is not equal thickness all the way around. Typically thins out where the apex is, and then thickens outside of it to try to maintain a little bit of the anterior contour uniformity as much as possible to still give good vision. And that remodeling is why topography, anterior topography, doesn't you catch the earliest keratoconus patients. And so, case in point, if we look at these three maps that I have here, all three are my real-life patients. Most of us will say, well, no-brainer, right? If you have to choose which in order of likelihood, typically the top two, the one on the right-hand corner and the left-hand corner, are the ones that are much more definitive about, that's definitely a catted cornea, whether it's keratoconus or ectasia, and then maybe questionable with the one in the middle. But in this case, the only one that is actually a true keratoconus patient is the one in the middle, where everything looks pretty. There's some, weird signs going on, but nothing extremely steep, because that's typically what we're looking for, those hot spots. And therefore, color recognition, it works for moderate and severe keratoconus. Yes, that's likely enough sensitivity for us to catch, especially corresponding to what we're seeing in the slit lamp and patient symptom. But somebody who is a truly, really early emerging type of keratoconus, using that color recognition, looking for the steepening red hot spots, it really doesn't serve us well, and certainly doesn't serve our patients well. So another example of a patient of mine, if you look at that, it's not even inferior steepening. In the photo on the left-hand side, that's when the patient first show, cylinder spectacle-wise and contact lenses-wise was like a 275, one with the rule, 170-something, 180. And we went through, we had all the mappings done with a shine fluke image to look at posterior and anterior elevation and profile, wavefront aberrometer, refractive error, corneal signs with slit lamp dilation, nothing to see if it's any other pathology, just nothing really let us believe that it was a corneal problem. A year later, still 2020, now you start to see possibly a little bit of inferior steepening, although overall the K values are still pretty flat. But that a year later, if you look at the shine fluke image with a pentacam here, yes, topography still looks a little strange, not quite sure that's definitely definitive appearance of a keratoconus with inferior steepening, but and also looking at pachymetry, that central pachymetry is 560. In no way is it a thin cornea that we typically associate keratoconus with. The thinnest portion of the cornea is about 530 at that stage. So again, not extremely thin, not even remotely to be called thin. But however, if you look at the posterior elevation, so meaning we're looking beyond the anterior contour now, if you look at the posterior elevation, which is this right here, the bottom right of the 4 maps, you can see there's a red spot here that tells you there's a point that is very outpouched or elevated. So posterior cornea contribution is often ignored in a lot of our diagnostic instrumentation, but it actually can be very helpful. So again, in a very severe case, yes, just looking at topography, such as in this case, just looking at topography is pretty diagnostic, right? You have that almost crab claw type of sign, which can happen in an inferior keratoconus case. It doesn't have to be a pellucid. And you definitely would say, yes, there's inferior steepening. And so looking at the cornea and the refractive status, that's probably enough. Remember, this is basically a moderate, probably severe keratoconus already. The area of thinning is roughly about 438. So that's a very thin cornea, right, compared to the 530, 560 I was showing you, who was still a keratoconus. Obviously, there's a lot of distance between these two people. So it's proving to you that the one that I showed you first was a very mild, early emerging patient, even after having been followed for a year, year and a half. And here, don't even need to look at the elevation. You know that posteriorly, highly, highly elevated, and anteriorly also very elevated. But again, in a moderate and also severe keratoconic patient, looking at topography, yes, is a lot of times gives you sufficient data, but that's not who we are after. Now that we're able to stabilize patient's condition like we talked about, we're going to talk about cross-linking a little bit later. So if we want to try to catch them now as early as possible, it may not have mattered before as much, because if they're not symptomatic, one eye still, a lot of, how many times have we seen keratoconus patients showing up and one eye being 20/20, the other eye is way worse than that, but binocularly they don't really notice it, which is why they waited and waited for a long time. So it may not have mattered before when our choices was really indeed just surgery such as corneal transplant versus contact lenses. As long as patients visually are doing well, it doesn't quite matter to them when they were diagnosed. However, now, since we want to actively make an impact and improve their quality of life and make sure they don't lose any more vision than they need to, and having the ability to stabilize this condition, now we want to strive to detect this disease as early as possible. So I show you the fact that from that very first patient that with the questionable mapping, a year later still being 560 in the central pachymetry or central corneal thickness. So it shows you that one point, and especially the central corneal thickness point, is not the most reliable. In fact, it's very unreliable to predict who has abnormal cornea. Distribution of it, looking at the thinnest point is an improvement, and then combining and looking at the thinnest point as well as the distribution of how the corneal thickness and the sloping of the cornea, how it progresses towards the periphery, can be really helpful, and that's what you are seeing here, where just very quickly looking at this is a pentacam where you have 2 standard deviation of normal. The middle line is normal, and then the red line is the actual patient. So a very severe keratoconus, you can see that the sloping is quite extreme and falling outside of the 2 standard deviation here, which tells you that since the rate of thickening is so much more exaggerated in the periphery compared to that of a normal cornea, there must be some level of thinning somewhere in the center. And that's how we can also catch somebody who is more emerging a mild form of keratoconic disease. And like I said, weakening biomechanics, right? Apoptosis of keratocytes. So in the future, we'll be able to hopefully incorporate this type of technology into our practice, where you could see 2 cornea of very similar corneal thickness. One is actually the normal variant, so thin but strong tissue, and one is thin and weak tissue. Keratoconus in the red line, you can see how much floppier its dynamic response is to 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 a certain force being inflicted onto the cornea, and that is an instrument that is not yet approved, but I am getting the sort of backdoor tips that it probably will be approved sometime over in the middle of or the end of next year. So I'm really holding my breath for having this approved in the United States. Regardless, we are really trying to get away from the conventional treatment approach of just diagnosing anytime patient shows up when they have symptoms, and then try to keep them visually happy with glasses and contact lenses, just monitor them until they have to go and receive a corneal transplant. Obviously not all patients end up with a corneal transplant because we are so good at what we do with contact lenses. The majority of our patients can stay in contact lenses, but not all, and that's why it necessitates the new approach that we have, where we need to stabilize as early as possible. So now early detection is extremely important, and also educating patients that we need to, not in addition or after stabilizing the disease, we can then do our best at making them see better with glasses or contact lenses. So it's going to be a two-stage approach, not just sort of stabilizing with corneal cross-linking and that sort of fixes all. That is possible if we catch them extremely, extremely early when they haven't even noticed any signs of high-order aberration-related symptoms, and we're simply catching it on, using more sensitive instrumentation. So that's a possibility where you just stabilize them and they still have good vision, and that would be ideal if we could do that. So cross-linking, then, as I alluded to, is what now is becoming really the new foundation of this new care model for keratoconus patient, where we want to first stabilize their corneal condition as early as possible, which means we have to detect their disease as early as possible. So the research on corneal cross-linking came out of Dresden University in Germany with the three main investigators that I have listed on the slide here. The current mechanism is unclear in terms of where that covalent bond formation is being added, that cross-link, right? So we do know the end result of tissue getting stronger. We know that it's very likely it's due to the formation of additional covalent bond, almost adding back the biomechanical strength of the corneal tissue. We don't quite know at what level. Probably my bet is more in the sort of collagen proteoglycan extending into the cellular matrix. The covalent bonding force can only extend a short distance away, so it can be maybe possibly in between the fibrils or within the fibril, and stiffening of one fibril individually, or between the fibrils and the sort of protein chain that's extending into this extracellular matrix. Those are all obviously possibilities. But again, we know the end result, which I'll show you in the next few slides. We know the end results. We know this works. It has been studied extensively in the last 15 years or so, if not longer. The method that was decided from the Dresden study was to use a photochemistry such as with UV light. The energy of UV light can't just be, randomly transfer onto the cornea and lead to the necessary photochemical reaction leading to cross-linking. It requires the intermediary molecule to absorb the energy of UV light and then pass it forward to different reaction sites to create the covalent bond. So the photosensitizing molecule was decided riboflavin was selected to serve as that compound. There are other agents that could lead to cross-linking effect biologically, but this was what they felt was the safest and most efficient combination with UV light, typically somewhere in 365 to 370 nanometer wavelength, and that's because the peak absorption of riboflavin is 366. So the light that we use in the United States that's approved by FDA emits a 365. And so there's, reasons these things aren't randomly decided for, no scientific basis. And another reason why riboflavin is a good substance to use is that it also acts as a tissue protector in that it absorbs UV energy so that it has a gradient effect of titrating down the UV energy as it penetrates to a deeper level such as that of beyond 400 micron. The energy level transmitted is so small that it's way less than the damage threshold of your endothelium and your crystalline lens and your macula, that type of thing. So the safety has definitely been proven in a lot of the studies, especially the original protocol that removes the epithelium. You can see the epithelium is removed because the only area that lights up is where the riboflavin it penetrates into the stroma, and it penetrates most easily when the epithelium is not in place. So that's how you know that it's an epithelium off type of cross-linking. Again, laboratory studies early on shows significant increase in the through Young's modulus or stress strain type of testing, and you can see different settings will lead to different amount of stiffening. But definitely with cross-linking, such as shown here in the riboflavin-soaked tissues with the yellow tint versus no cross-linking with very flaccid and very floppy tissue, you can see the difference. And the first landmark paper on on human subjects was released in 2003 by the investigators that I told you from Dresden University, showing it's a small study of 20-somewhat eyes. It's a pilot study showing, however, 100% of them who were previously progressive prior to cross-linking treatment, a year after being treated and a year later, all stabilized and actually have some topographical improvement in that their keratometry value over the apical area actually decreased by about, I believe, on average 2.1 diopter from that study. Our U.S. data shows more something like, for keratoconus patients, something more along the line of 1.6 diopter at a year later. But regardless, that shows that although we're pleasantly surprised that with the reversal in the apical area, that's not always meaningful refractively. So it's important to educate our patients that this is really, if you get some visual improvement, great. You're likely going to need contact lenses if you're already wearing contact lenses, or if you're currently spectacle wearer, you probably will go back to wearing glasses. This is really just trying to stabilize those with keratoconus and ectasia. And like I said, with the with the very carefully calculated energy dose of that's why it's important to know what energy levels being emitted by the light device, and that it doesn't have any hot spots in the beam profile emitted by the light, as well as having enough thickness, typically 400 micron, as I explained, because in the theoretical calculation, having the 400 micron, having enough, having proper and uniformly or homogeneously distributed riboflavin within the stroma, it will decrease the light energy level UV light to a very safely tolerated level by the endothelium, crystalline lens, and the retina, which is why those are usually, although early on, as long as 400 microns being respected, which is another reason why you don't really want the patient to continue to progress and then progress and really get thinner than 400 before you make that referral. We want to now do the opposite. We want to try to manage that patient as early as possible. I think, however, what is more in the list of potential risk factors here, I think what is more realistic to discuss with our patients is the potential loss of best spectacle corrected acuity. In most studies, it does show that there's pretty consistent. There's always a small group of patients who have some loss of best spectacle acuity. However, in our study that from the center I was at, those patients continue to do fine with their contact lenses. So even though we couldn't explain why they had lost vision, nothing to do with haze, nothing to do with scarring or anything like that, they continue to do really well with contact lenses, and so it doesn't seem to bother those patients. And in fact, if you look at the multi-center study done within the United States, looking at keratoconus and ectasia patients after cross-linking, the group of patients who actually gain vision, 2 lines or more, is roughly about 4 times more than the small group of patients who lost 2 lines or more. So I feel like we pay a whole lot of attention about a very small group of people who lose spectacle vision but can continue to do really well with contact lenses, and we kind of make a big deal about that, and we don't really look at the fact that most people either their vision is the same within plus minus 2 lines, or they actually 20-somewhat% of patients gain about 2 lines or more. So even though that's not something that I would want to impress on the patient in terms of, hey, 20-somewhat% of patients get better, I talk to them really more about stabilization. I just kind of want to make sense of that clinical concern about loss of best acuity. I do tell the patient, but I make them understand that it's really very rare and uncommon. By that I mean a very small percentage, and possibly continue progression, right? Just one treatment may last a certain amount of time. On different individuals, it's been reported to have different longevity of treatment effect, and therefore they still need to be monitored very closely, whether it's every 6 months, every year, pending your comfort level with the patient. Certainly you don't want them to think, oh, I'm cured with the cross-linking, so now I don't ever need an eye exam anymore unless I lose my contact lens or something like that. So I think those are things that we need to discuss with our patients. And here's a case from Dr. William Tretler. Just want to show you, and it's actually an epi-on type of cross-linking. Just want to show you the flattening effect, and it's actually quite exaggerated in some of these patients. Certainly not all the cases. Like I say, our U.S. data on average shows about 1.6 diopter of flattening. And not the same patient, but also another case from Dr. William Tretler, showing that cross-linking even though we typically think that majority of the flattening and topographical changes, improvement, if we're going to see any, typically is that first year or maybe up to 2 years. There's some studies that slowly are showing 3 years and 4 years, you're still seeing mild changes. In this one case from Dr. Tretler, it's actually showing even continual flattening even into year 6. So it is possible that it can last for much longer in some patients. Who's going to benefit more from cross-linking in terms of getting more flattening effect, in terms of maybe getting 2 lines or more improvement in their best spectacle vision? We really don't know. I wrote a peer-reviewed publication on interim data analysis on which group of patients. So feel free to refer to that article. Reach out to me if you couldn't download the PDF version or find the PDF version. I'm more than happy to send it to you. And again, just want to say that I want to repeat again, make sure we educate our patient with our current iteration of cross-linking, meaning there are other research that are now undergoing, trying to bring about more refractive improvement in our patient after cross-linking. But current iteration of cross-linking that we have right now really is just to stabilize the corneal condition. Patients still need their glasses or contact lenses. Again, try to avoid rubbing, whether it's before cross-linking or after, and try to actively manage any type of ocular surface condition that can lead to that can act as a stimulus for rubbing. And generally, a quick patient education, their keratometry, even though we talked about flattening being seen at 6 months or 12 months later, that initial first month, their Kmax, or looking at topography, their apical area actually gets steeper. And that's likely because the epithelium hasn't completely remodeled itself, because it heals very quickly, but it takes some time for for it to redistribute itself to kind of thin out over the apex and then sort of thicken outside of the apical area. So that probably is what we suspect is the reason for why you see that early steepening. Anyway, so and typically I just want you to not feel like, oh, the patient's a cross-linking failure because things are getting worse. You typically do see that after a month, and around about 3 months they return to baseline, and slowly you see that flattening effect if it's going to happen towards the 12 months. And the visual acuity, thinning of corneal thickness, kind of follow all the same trend. The vision gets a little worse by month 1, return to baseline by month 3, and if there's going to be some improvement occurs towards the 12 months, somewhere past the 6 months to the 12 months. So just make sure that you're able to verbalize those findings with the patient so they understand what to expect afterwards. Some research have looked at the fact that, well, if cross-linking by itself isn't going to really bring about, again, the current iteration of cross-linking isn't really going to bring about refractive treatment, at least not in a predictable manner. Could we potentially do what foreign markets are now calling it a TCAT, TCAT, which is really cross-linking combined with a topo guided PRK type of treatment? And you may think, wow, that's crazy, right? It's super aggressive. If somebody's already having keratocystic apoptosis type of disease where the tissue gets weaker, probably further ablation is not a good idea. And I would agree with you if it wasn't for cross-linking, right? I would not recommend that by itself to a keratoconus patient. So what this does is it recommends, and again, this is if somebody really needs some form of more major improvement in their corneal contour or some form of refractive improvement, which I would say a lot of keratoconus patients want that. And again, this is not currently approved in U.S. I just want to make sure that I said that. So the ablation is very minimum. It's not aimed to correct the huge amount of refractive error. It actually came about as a theory to say, hey, if keratoconus patient, the apex is the thinnest portion, and it probably, in contrast to other part of the cornea, is the biomechanical strain on that thinnest area is probably the greatest, whether it's from IOP vector force pushing outward or eye rubbing if that's happening. So if we equalize the contour a little bit so they're a little bit more even, would that then be able to the amount of pressure being exerted on the cornea to be a little bit more even so it's not all falling on the apex being the greatest point? I mean, in fact, it's always going to be the greatest point on the apex, but it hopefully brings that down by a few notches by way of just smoothing the contour of the cornea. So it's really more, it's not aimed to optically manage the patient. It's more for its therapeutic value, the way I explained. And so it doesn't aim to take away too much tissue, typically 50 micron. I've heard as aggressive as 70, then cross-link the stromal bed after that. You have to take off the epithelium for an epithelium off cross-linking anyway, so it's the same thing as a PRK. Ablate very small amount. Obviously, you're going to tell the patient, hey, we cannot predict how much refractive reduction this is going to occur. It really is more to just maybe enhance the stability of the cornea after cross-linking. If you get some improvement, that's great. And I've had patients who travel overseas for this treatment and came back and are, extremely happy. So. And just to show you here a combination treatment with cross-linking and topo PRK, you can see that the tissue is a little bit stronger in that it's not being pushed in the bottom frame. Let me show you one more time. You can see that pay attention to the amount of distance of the cornea travel and how floppy it is at the end. You can definitely see improvement 10 months later in the bottom frame. So this is a patient of mine who actually traveled all the way to Greece to have this done. We did the cross-linking and the Intacs, but the patient was seeing really well with scleral lenses but got tired of wearing a scleral lens and wanted to see what PRK can do. So PRK have been done either simultaneously right after cross-linking or have been done 6 months or a year later in literature have reported that. And this patient sort of just went for it and came back and was seeing maybe a line worse than a scleral lens, but he was happy enough because his fellow eye was really good, and that means that he gets to wear a soft lens in the fellow eye, and then the eye with that he received his topo-guided PRK, he just felt like that was good enough. He didn't want to put on another contact lens, so he was really happy. So I just want to show that it is possible. And that's where Intacs can make an improvement. I know it sort of gets a bad reputation because it's similar to corneal transplant, right? If you promise patients that that is going to be the panacea of your condition, whether it's corneal transplant or Intacs, it's going to fix everything. Of course, you're going to have a lot of unhappy patients. So I feel like it's more patient education. Certainly, recent technology have evolved in having more than one form of Intacs. More than one form of intracorneal ring segments, such as the Ferrara rings in Europe that is used very common as well as in Mexico. We have in U.S. Intacs. And also the channels can be made with more precisely with a femtosecond laser now rather than manually, such as the one I'm showing you here. All that can add to the fact that we may have better results from Intacs. And really, honestly, it doesn't create that much more elevation, which means your contact lens fitting is, especially with now your hybrid lenses, your scleral lenses that can vault over a lot of different area on the cornea, really contact lens fitting is not something that is very difficult after Intacs anymore. And also the fact that we actually have many study results that have corroborated the finding that I'm showing you here. This one that I'm showing is from the center I was at. It's a single center finding that we used to think that you need to put in, at least 2 segments, right? As many segments as you can, because it used to be a whole ring. And actually, a lot of studies are showing maybe 1 segment inferiorly is actually going to create the most amount of redistribution of the topographic, that irregular contour. Maximum, you can see the very bottom one where if we have 2 Intac segments versus the 1 segment leading to almost 7 diopter flattening combined with cross-linking. So that coupling effect seems to be better when coupling Intacs with cross-linking together, seems to be better with 1 segment, which means that it's going to be easier to fit, right? Because if you worry about the elevation circumferentially with 2 segment or a ring, now it's only 1 segment. It's going to be, the fitting-wise with a contact lens is going to be easier. So a case that I have here with this patient who actually had 2 segments put in somewhere else and came to us because she has noticed her vision is declining and she wants to wear contact lenses and simply because she couldn't tolerate her glasses due to the anisotropia, much worse in one eye. She has 4 diopter of cylinder in the right eye where she was spherical in the left, so she couldn't tolerate spectacle. And we told her that possibly with the sort of new treatment principle, if we could exchange her Intacs, take both of them out, put a thicker segment into the inferior portion, we may be able to reduce her corneal cylinder a little bit more, but we couldn't we told her that she likely will still need to go back to contact lenses, and in fact what's probably better if I could just fit her with contact lenses first to see if she could be happier with a scleral lens or hybrid and other things. But she insisted that she wanted to wear soft lenses or glasses, so we gave it a try. You can see that the amount of cylinder has significantly decreased to 1.25 diopter, which now she could actually tolerate spectacles with her -4 in the other eye. And actually I put her in a soft toric lens, and she was very happy. And even though if you look at her uncorrected vision before and after Intac segment exchange, and also her best corrected vision for us with spectacle, it didn't really change very much, and most people will look at that as a failure, but she is so happy. And some people think that let's see if the video is going to run here. Some people think that it is possible that Intacs can add a little bit of biomechanical strength back into the cornea. That's not the purpose, but you can definitely see that it doesn't. You can definitely see here that it does not. It seems to be holding definitely with the bottom frame. You could see that the cornea doesn't cave in as much. So it is a possibility. And for some of our patients, we also offer if they need further reduction in their corneal cylinder after Intacs, after cross-linking, obviously after some time had gone by, so we know that we're reaching hopefully the majority of the flattening effect from that combo treatment, and maybe even topo-guided PRK if they went to Canada or Greece or something like that, came back. We typically, after Intacs and cross-linking, we have offer patients a conductive keratoplasty, which is using radio frequency emitted from a probe into the cornea. And what it is it's almost the heat is very uniformly and slowly transferred into being absorbed by your corneal tissue, and therefore basically contracts, right? So it's almost like plastic wrapping, if you would. It's almost like your plastic wrapping, you're applying heat and kind of shrinks. So that's what's happening. And what it does is it exerts different amount of vector force. So if you, onto the cornea and change the contour, and this is what you can see right after, immediately after the CK treatment. So if you strategically place the spots correctly, you can change the contour in these patients. And this is a patient, you could see these white spots is where we did the CK treatment. We had actually removed the top segment of the Intacs, leaving only the bottom, and had cross-linked the patient. And again, the patient's really happy and doesn't even mind going back to contact lenses, just wanted to have a little bit more functional vision at home after taking out the contact lenses. So some new trends in cross-linking. Remember I told you about the fact that they're looking at some other research in delivering cross-linking that can have a little bit more refractive effect. So this is called photointrastromal cross-linking. So what it is putting more energy in area that is steeper or thinner or weaker, and so that it causes more contour changes, more flattening to the area that needs to be. And it's topography driven. So the energy level that is being projected into different areas determined by the amount of the keratometry changes, and therefore bring about more, if you would, in very highly customized cross-linking treatment. And there's another pattern of that kit this is the treatment pattern that is being planned for this patient with this type of topography. So very quickly in the last few minutes, I think I have about 5 minutes to go. So let's talk about corneal transplant. And different form of keratoplasty, obviously your lamellar your deep anterior lamellar keratoplasty actually has become rather popular as a refractive treatment because it keeps the endothelium of the host eye. Right? So we know that one of the concern about full penetrating PKP is the loss of endothelial cell from the donor tissue. So if you and we know optically the most amount of change that can be affected comes from anterior contour. So this fits actually quite well for a keratoconus patient. And if that obviously, if in the OR, if for some reason your lamellar keratoplasty cannot be done, the surgery can always be converted into a full penetrating keratoplasty. But the problem with this is, especially our traditional method, is it's very difficult to line up the tissue with the host at the junction and not cause and run your, whether interrupted or running suture all the way 360 and be able to exert equal tension so that there's no tilt. And also wound healing response is such that you cannot control the amount of cylinder that may occur as the cornea heals. And sometimes year after year, the corneal cylinder in a post-corneal transplant case can actually increase. So it certainly isn't a static, after a year, after two, that refractive contour of a corneal transplant is going to stay the way it is. So those are all challenges of a manual penetrating corneal transplant. We talked about the fact that femtosecond laser intralase is, which is a type of femtosecond laser, is helping with the Intacs channel, making it more precise. It can also make a pattern keratoplasty, which this is a mushroom cap. This is a top head. So, what it would do is it can fit into the configuration of the host tissue because the host tissue will be cut in the reverse shape so that they fit into each other like a jigsaw puzzle. And so they're more watertight, less worry about suture. And also you can, depending on the configuration here with like a mushroom type of configuration, you could save more of the endothelium from the host, or if it's more of an endothelial problem like Fuchs, you could actually take out a little bit more endothelium and use this top hat type of configuration, so on and so forth. So this really is transforming, I think, our corneal transplant technique. Let me just very quickly play this video for you. I may speed it up. It's a short video. So it shows you the using intralase, using femtosecond laser, cutting the pattern on the host tissue, on the donor tissue, I'm sorry. And that was the docking. You saw that this is now the host, and the docking of the intralase or the femtosecond laser station, and cutting the reverse configuration. And then I'm going to speed up a little bit. You can see that, and then cutting into the cornea on the host completely, so you could see the viscosity of the aqueous humor a little bit as the tissue is being lifted away. You can now see there is a track here, right? So it shows you, and there's a reverse flap that fits very well underneath that. This is a top hat configuration on the donor. So you can see now they kind of fit into each other. So you can put either less suture or not, or you can release the suture a little bit sooner because of stability at the host graft junction. So it's something that can, again, right now, I think in the future, once we figure out exactly what to do, possibly could, I do think this carries a lot of potential and bring about shorter visual, meaning quicker visual recovery time, and maybe shorter return time back to contact lenses if that is what's needed for these patients. So I would be remiss if I don't quickly mention that we do this better than anyone else. Obviously, after any type of surgery, a lot of times contact lenses are still needed, and so don't underestimate the power of contact lenses. In fact, from the study that I told you that we did during my fellowship, during Dr. Shin's fellowship, actually, we looked at 329 eyes, chart review, consecutive 329 eyes, and shows that those who went to contact lens fitting without surgical intervention, such as cross-linking Intacs, versus the group that had that feel like they could not tolerate contact lenses. As you can see, their self-proclaimed tolerance level when they show up at their first visit is much lower compared to those who are willing to undergo contact lens fitting first. But you could see the contact lens tolerance after surgery versus going to contact lens without surgery actually comes up to about the same point afterwards, proving that surgery can have synergistic value to contact lens fitting when proper contact lens fitting is done afterwards. So certainly surgery doesn't always mean that a patient would have some sort of psychological issues about the benefit of having contact lens fitting afterwards, just need to be properly educated. So that's, again, the importance of being able to defer using this new treatment model to stabilize, detect as early as possible, and try to catch them early on so that we can ensure the longevity of glasses or contact lenses that we give them defer corneal transplant as long as we can, which is something that I think we all love to do, and also be able to just educate patients, even if they're stable. Pregnancy, for one thing, has been shown to cause more keratoconus progression or even regression from cross-linking treatment effect. So family planning, if your female patient is planning to have children, it's something to then have to should carefully discuss with our patient. So co-management is key. Being able to refer for now, for medical treatment with cross-linking, come back with to us, and then be able to give patient the best contact lens or glasses prescription possible, and maybe very possibly in the future, we be able to even perform cross-linking in our offices. So certainly looking forward to that if that's a possibility. And just before we leave, want to give you some more resources. So if you're interested in finding out more about keratoconus, I am on the executive committee for International Keratoconus and also Medical Advisory Board of the International Keratoconus Academy. It's being led by Dr. Barry Iden, who's also is speaking at this event. So do check out his lecture. And if you're listening to the videos after the live event, please also go check out his recorded video. But the mission of the IKA is to share knowledge with our colleagues. So please contact, and the membership right now is free. And I also have additional infos here for you on more resources that you can check into. But definitely check out our International Keratoconus Academy. Membership is free, so go on to the website, and look forward to seeing you. Any question, feel free to follow me on Twitter, LinkedIn, email me, and I thank you for your time and attention with this lecture, and I hope that be able to see you whether in person or another lecture in the future. Thank you. Bye-bye.